Good afternoon, all of you. It's difficult to talk after a lunch session and even more difficult to listen. So I'll try to keep it short. You all have clinical risk scores when you're trying to predict the event of or the presence of a significant coronary artery disease. You have the Framingham risk score and the ASCVD, which is more in addition to the cardiac risk score, it also gives risk of stroke and other illness as well. These have got limitations in terms of predicting the exact risk. So if we add another indicator, such as a calcium score, which is done on a non-contrast gated CT, studies have proven that all-cause mortality and morbidity in CAD individuals, the prediction can be much better if you use a clinical score alone. And coronary calcium score has reclassified in a significant proportion of patients. It has either downgraded the risk or upgraded the risk when you added the calcium score to the clinical scores in up to 45% of individuals, especially in asymptomatic CAD disease. Now, after you obtain a non-contrast gated coronary CT, you got three methods of quantifying that. The most popular is called as the Agatston Score, which uses the plaque area and the density of the plaque by a attenuation weighting factor, which is the widely available, very simple to perform, easily produced, reproducible. Sorry, it's not easily reproducible. That's another disadvantage of that. But it's easily provided by the vendor-specific software. Automatically, it hardly takes 5 to 10 minutes to do the scan and get the analysis as well. But the pitfalls of that would be there are variations in image noise. So if you have got more noise coming from the adjacent tissues, so you have got a annulus calcification or aortic valve calcification, you could have streak artifacts which could result in reduction in the efficacy of this particular result. And one of the significant things is a limited interscan reproducibility. You perform now and you perform later from the same data set. You could have differences in values. But however, it is the most widely available procedure. You've also got the volume score and the mass score, which are not as widely validated and not widely available. So as of now, it's mostly the Agatston score which is in place. So this is one example of an extensive coronary artery calcification involving all the arteries, but in the pictorial you see the LAD and the left main showing extensive amount of calcification. The score here is around 1047, which signifies a high risk of coronary artery disease. So, as I've said, when you combine the clinical scores with a calcium score, you got one popular multi-ethnic study of atherosclerosis, the MESA score, where you could downgrade or upgrade the prognosis based upon that. So, but one pitfall I found that is you don't have a South Asian race or ethnicity in this model. You have got only Caucasians, Chinese, African American, Hispanics. Maybe if you have a South Asian model as well, it will be more predictive of our country as well. So you can analyze or prognosticate the coronary calcium scores. You got a score of 0. It means that there is a very, very low risk of having a coronary artery disease, but it doesn't say that you've got a 0 risk. 0 doesn't mean 0 because you could have non-calcified plaques as well, depending upon the clinical pretest probability. 1 to 100 is mild, moderate is 101 to 400, and you got a score of more than 400 Agatston score. It implies a severe cardiac disease, probability of severe cardiac disease. Now, when you combine a calcium score with, if you're trying to start statins based upon the clinical scores alone, especially in the borderline and the intermediate risk, majority of them or a significant proportion of them would be undergoing statins. But if you club this with a calcium score, so if you have a calcium score of 0 in a borderline or intermediate risk patient, you don't need to start statins according to the recommendations. So this is a 60-year-old asymptomatic man, significant calcification of the LAD and the RC arteries. He had a borderline risk at clinical evaluation, but the presence of high coronary calcium in this particular patient would upscale this particular patient from a low risk to a high risk status and would warrant a medication appropriately. The limitations of coronary artery calcium include limited detection of plaque. It only detects the calcified plaque, the high density plaque, but the low density plaque would not be evaluated. Of course, it doesn't have any functional assessment. Non-coronary causes cannot be assessed, and it's not suitable for all patient populations, especially a calcium score of 0 in a high-risk patient, such as a smoker or a high cholesterol, doesn't mean anything. It's probably fallacious in that particular situation. Should the calcium score be repeated in future? Especially if the calcium score is high, you don't need to repeat it. High calcium score itself upgrades the particular status of the patient to a high risk, so you don't need to repeat it. But if a calcium score is 0 and you repeat at 5 years, it is still 0. It's called as a double 0, and the risk of a 10-year event of a major cardiac event is pretty much less as compared to a calcium score, which is higher. So in summary, it is appealing because it's simple, no contrast is involved, the radiation is 1 to 2 millisieverts. But as we have said, the limitation is non-evaluation of non-calcified plaques. So who should get it? Those between 40 to 70 years, asymptomatic and at increased risk for heart disease. And people less than 40 years with a familial hypercholesterolemia or a family history of premature CAD could also get it as well. So in conclusion, it's only one piece of a overall risk stratification. It should not be assessed in isolation. It's always should be assessed in conjunction with the clinical findings. And it should never be performed in patients with chest pain in high-risk individuals.